TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Hello and welcome to TopMedTalk. We're coming to you live from the World Congress of Anaesthesiologists here in Marrakesh in Morocco. This is the 19th Congress. There are more than 4,000 delegates from 150 countries around the world. I'm here with my co-host, Mike Grocott.
Great to be here with you. I've just come running from a session on hemodynamic management.
Aha!
So, literally finished about 2 minutes ago.
Awesome. Now, I've come running from a session on being unambitiously ambitious, unapologetically ambitious, sorry.
I tell you what I particularly enjoyed, the Harold Griffiths lecture yesterday. We are lucky enough here today to have with us Professor Adrian Gelb, past president of the WFSA. I can't even find the words to say it. Evidence Based of Anaesthesia, who has kindly joined us on TopMedTalk. So, Adrian, thank you so much for joining us.
It's great to be here and good to see you, Mike and Kate. This truly is a wonderful experience and a great congress.
So, fantastic lecture yesterday. Could you give us a little bit of an introduction as to your background and your journey through anaesthesia?
Yeah, I grew up trained in South Africa. That left me with an interest in the less privileged in the world. From there, spent the next 30 odd years in Canada and then the last 20 years at UCSF in San Francisco. My interest in the less fortunate in the world, lower resource settings, has continued through my career in different ways, including trying to host people in my departments in Canada and in the United States. And then through Alan Mary, I give Alan credit for getting me engaged in the WFSA specifically and the Patient Safety Committee, and for WFSA giving me the opportunity to kind of stretch in terms of interest and to use the opportunity to work with the World Health Organization. WFSA is, in WHO jargon, a non-state actor in official relations. So WFSA can make statements to the executive board and the like. And I jumped on the opportunity to try and raise the profile of anesthesiology. I'd have to say, up until Alan got me engaged on a patient safety committee, I had always thought of patient safety just as an integral part of clinical care. And I was very resistant to this notion of it's a separate committee, it's a separate activity. Now, I understand how those things happen, but it's always seemed to me at some point we need to bring it back to where it belongs, which is directly in critical care. We need to get out of the side rooms we get at conferences and in our departments and bring that back into action.
One of the themes I took from your presentation yesterday, which was really good, was a much more system-level approach to everything. So obviously, in the final analysis, it's down to what happens to individual patients, but a lot of your solutions appear to be systemic, national policy.
Absolutely. You know, if one looks back, and I guess one of the few advantages of getting older is that you can look back a long way. And I've always had an interest in anesthesia history, or how did things happen? How did we land up here? And when one looks back, that dramatic change that took place over the 80s and 90s and those sort of 20 years were a systems change. And so it seemed to me, if we want to make the same impact again, we really need to change the systems. And as I mentioned in the lecture, for people who look to change behavior, implementation people, knowledge translation folks, human factors engineering, it's been clear for decades that the key to changing behavior is changing the system in which the behavior takes place. And so I've just slowly come to realize that if we want to improve patient safety in anesthesia, we actually need to start changing the workflow and the environments in which we are trapped.
I come from Australia, and in particular from Victoria, which is a world leader in road traffic safety. We got a seatbelt law in 1970. We then had booze buses, drug buses, speed cameras, mobile phone, etc. And we've achieved world best road traffic things. And last night here in Morocco, I got in a taxi that had seatbelts in the front seat that weren't being used by the driver and no seatbelts in the back seat. And it just felt completely unsafe.
One feels naked.
Yeah, and our government made this behavioural change in Australia through a multi-pronged attack, which started with laws, with, surveillance, but then also with a really sophisticated media campaign with really cool ads. Like, if you drink and drive, you're a bloody idiot, was the,
I know, very sophisticated.
Yeah, but it, resonated with the populace. So I'm not sure that that in health and in anaesthesiology we've got quite the same levers to actuate reform. Do we have financing and payment levers, or regulatory levers, or are we entirely looking for cultural change through advocacy?
I think we do have levers. The reality in politics is you have the levers, you develop and grow. We in anesthesia have been pretty passive-aggressive. We like to sit around the operating theatre and complain, while our surgical colleagues go off to meetings, or the nurses go off to meetings and do the business of the hospital. I interact with a fair number of governments in healthcare, informally at meetings. I see a lot of surgeons as deputy ministers of health or senior figures in political entities. I have never met an anesthesiologist in the last 20 years who is a senior leader in any government and who values the role of anesthesiologists. There are a few, and it seems as soon as an anesthesiologist gets into a senior political position, they forget their background. But we do have leverage in our hospitals. I don't envision a campaign that will revolutionize what we do in the short term. I'm thinking in terms of this needs to be a 10-year plan. Where do we start? We clearly have control in an operating room, because if we're not there, nothing actually advances. So we do have leverage in the crudest sense that we can and should use. Almost anybody can make an appointment with a hospital CEO. In general, you may have to wait, but you can meet. Department heads should be levering that opportunity on here's how we can make patient flow better, patient safety better, reduce the cost of liability insurance, and build a case out of it and keep going at it.
So it seems like, using the road analogy again, that what we're doing is changing the small country lane into a superbly designed freeway where it's harder to make mistakes for people, and that will change their behaviour.
I like that analogy.
You can use it.
Thank you.
Adrian, I was struck in your account yesterday of the extraordinary impact of the standard introduced by Harvard in the 1990s that achieved a very rapid transformation. Although we don't have randomized controlled trial evidence, I think from a safety perspective, we're all very convinced that that was beneficial. Could we do that again? How would we do that again? And if so, what are the really key things? If somebody said to you, Adrian, you can have a new standard next week, what would be the things that you would introduce?
Well, I want to jump back to that historical experience as a model. The article was actually published, I think, 1986, 1985. So they already had a little pilot study in their own hospitals to show that you could get people to use this technology. They didn't provide a lot of details on how many refused, just a sort of general statement that it was effective. But I think what was key was that Ellison Pierce was very taken with that initiative. He was, or very shortly thereafter, became the president of the ASA, and in that role created the Anesthesia Patient Safety Foundation. as an ASA subsidiary affiliated organization. And he got himself into a position where he could provide information to the Institute of Medicine's To Err is Human process. So he used that political opportunity. I wouldn't say it was just a single individual who did that, but this was a single individual in an important leadership role who espoused the message and used every opportunity to advance it. And there seems to me, perhaps naively, that there's no reason we cannot do that again with what we need to step forward. National societies, or leadership in national societies, often find themselves trapped in a sort of trade union mentality. I'm here because the members voted for me. We need the money from the members, so we shouldn't be doing anything that upsets the members. And I think we need inspiring leadership that will step beyond that and present a picture to national society members that your best interests are the patient's best interest. And that a message that it's all about my income or how early I leave is not the message that resonates with the public or with politicians at any level, be it government of federal, regional, or hospital governance. The message always needs to be, we're doing this for patient safety, and then we actually need to initiate the changes. We need to map out, in each local context, these are the little steps we need that will result in the big change. And that big change may happen long after I'm the president of this national society.
I think we've all served on national society. Kate, you've been a president in Australia. I was a vice president in the UK. And my observation, having stepped back from that, is that we often didn't achieve what you've just described. And actually, much of the time, national societies function much more as representative organisations for their members.
A trade union.
A little bit, and I'm not trying to minimise. Of course, there's a patient focus, but there's a tension there sometimes.
Indeed, there is. In the UK, as in Australia, there's a Royal College, or in our case, a college, which is the accredited training organisation. But we retain our former trainees as fellows or members, and we have to address their concerns and advocate for them. We have a sister organisation, a society or an association that in Australia and New Zealand is more engaged with the government on workforce issues and billing and things like that, but that also looks after their members and their CME. One of the most valued products or offerings of the Australian and New Zealand College of Anaesthetists, though, is our professional documents or our guidelines and standards. They have transformed operating rooms and PACUs and so forth in our region. They're widely used by our fellows and quoted. And the same goes for the Royal College and also the American Society of Anaesthesiologists. Influential guidelines.
I don't want anybody to have the impression that I'm in any way against guidelines. I just don't think the guidelines go far enough.
Agree completely.
In spelling out, these are the guidelines, and here are some ways in which you can make them work where you are.
They're necessary, but not sufficient to get the job done.
Exactly.
And in most cases, we've written the guidelines before we had a statement of standards. So we did it the wrong way round. And you were actually the one who led the standards. A standard says, anaesthesia is an important activity. It's not like it should be or it must be or, we'd like you to try to make it important or whatever. So you did that for the WFSA?
Yep, that was published in 2018.
This sort of implementation step, though, is pretty exciting, Mike.
It's very exciting, but I think in general we're not brilliant at it. And I was very taken by your invocation yesterday to really focus on the implementation side.
Absolutely. We need to focus on the implementation side. Hopefully some people heard the message that we are not experts, but there are experts out there that go by a variety of names. Implementation science is very much in fashion, and I've had some interesting pushback on that in talking about implementation with a hospital chief recently, and he said, I'm not really interested in a science project. some sort of project for publication. I just need to get this done in my operating room because I think it needs to be done. And I can't figure out a way to engage the surgeons and the nurses because in order to make this change, they need to be compliant or complicit in the change. Classic example is the safety checklist. Everybody needs to participate. And so, don't look for an implementation scientist, look for a human factors engineer, an implementation specialist, a knowledge translation specialist. They go by a variety of names, but it doesn't have to be turned into a research project as such. Although in reality, it is a kind of research project because you try something, you review its success, and then you replan, go to the next step. But that's what life is all about. That's how we learn. I think all colleges and physician associations need to do is to say, yeah, we're going to generate guidelines and we're going to help people implement them. I think we could deliver the same message. We're sitting here in an industry exhibit area for industry. You want us to buy this technology from you? We need you to cover the costs of whatever the implementation piece is. That isn't just your salesperson standing in an operating room. That's you helping us understand our context, the issues in our operating theaters, neurolocations, and the like, and how we best position this technology in each of those areas.
So our guidelines are incomplete without that section at the end, or it's a separate activity? How does it fit in?
Yeah, and picking up on Kate's analogy about highways, it would be like reading the instruction manual on how to drive a car and what all the signs mean without actually being tested. You need to actually make those rules, and then you need to get into a car and say, is this actually practical? How do we navigate around a city given the guidelines that we've developed?
You've had this long and spectacular career. I assume it is not over. What are you planning to do next?
Oh, if I say it, I'll be obliged to do it.
No, not necessarily.
One of the things that I have been interested in is essential medicines and the
Yes.
WHO's approach to that.
Can you tell us what an essential medicine is?
The WHO would define it as a medicine that a population need.
Yeah.
Pretty broad definition. And what they've done since 1977, since the first one, is create what they now call a model list of essential medicines. The model list became a necessity with the plethora of antibiotics out there. So they sort of say, here's a group of cephalosporins, you decide which one you want to use in your country. But an essential medicine list is a list of medications in which healthcare could not be provided at all. It is a minimum list. Many countries have these lists. We've just reviewed 137 of them.
Wow.
And I can't remember if Australia has a list with anesthetics in. I was surprised there are a number of countries that don't seem to have anesthetic-related medications. Many countries have a separate military list, which is a little skinnier, but from the few I've looked at, invariably have anesthetic agents in them. So I've been interested in how the WHO goes about thinking about this. We've just been successful in making changes. We've had halothane removed now, and we've also had the language in relation to nitrous oxide changed to make it clear that it should be cylinders at the bedside, not bulk. What I would like to do next is to create a made by anesthesia list. These lists are made by other committees. Even at a national level, national societies may have input. The AAGBI created such a list, 10, 15 years ago, suitable for their own context, which I think is great. I think it was a great initiative. But I think that there'd be use in a tiered WFSA type list, that says if you're a low-income country, this is what you must have. If you're a lower middle income country, you need those medications plus these. And the same for upper middle income and then for high income countries. And at the high income level, it would be those 3 tiers and then whatever else you want locally. And if I remember correctly, the AAGBI needle list has about 20 odd medications on it. Some of them I think are important for your practice and my practice. They're the standard medications. But I think in a low resource setting, you could give a perfectly decent anesthetic without those 22 medicines. You could probably do it with 10 of them.
We're talking about the irreducible minimum of an induction agent, something to deal with pain, something to paralyze.
Exactly. But I would like to see that list built by us, as opposed to, as in the WHO case, an expert committee of psychiatrists, gastroenterologists, pharmacists, and the like. I think we need to build a list. We need to come up on what do we in anesthesia think of as our criteria from a utility and cost effectiveness and availability perspective.
Do you have a process in mind for achieving that goal? In terms of, building consensus, that kind of thing?
I'm fairly pragmatic about consensus. It's 51% sort of carries the vote most of the time. I could envision it perhaps as a very large global Delphi, which is what Karen Nanji and I, Karen is the PI of the project, have done for medication safety. And she'll be presenting part of that actually this afternoon. But the way we structured that was a Delphi of about 120 or 130 people from around the world with sufficient representation in each economic group. And for the purpose of safety recommendations, we've also included some token surgical input and nursing input in order to generate a tiered structure. So I'd envision using perhaps something similar, laying out or agreeing what are the criteria, and probably the WHO criteria of availability, utility, cost effectiveness would probably be quite reasonable. But I haven't really worked with a statistical advisor on can one do this and make it a reality.
Great project. When you're ready, come back to TopMedTalk and we'd be happy to promote that.
I'll hold you to that, Mike.
I have one question, or not a question, a request. The denouement of your presentation yesterday I thought was lovely because you turned it back on us, and I don't know if you can just go through a little bit of that again, just share with our audience, because you may not know, but it's on the screens all round the Congress. When I went into my session this morning, you were there, Adrian, in those final sort of 2 or 3 minutes. So I don't know if you can kind of share that message for our listeners.
So the title of the lecture was Can Anesthesiologists Lead Again? And the answer to that, I think, is pretty simple. Yes, we can. But the really crucial question is, will we lead? And the only way we can lead is if we are leading in the operating theater, in our department, in our hospital administrations and the finance committee, with our politicians, in the Ministry of Health and the Ministry of Finance. We need to deal with both of those, and our national societies. And it's really in our hands. Is this important enough that we want to be the leaders, or do we want to just be the followers? It's yours, dear listeners.
It's a wonderful message and a great way of finishing this for us. Adrian, thank you so much for joining us. Thank you for listening. Thank you to our sponsors, particularly BD and GE, making TopMedTalk possible and free open access for the world. Thank you to all of you for listening, and thank you in particular to the World Congress of Anaesthesiologists for enabling us to be here and sharing all these great podcasts with you. Thanks very much, Adrian.
You're welcome. My pleasure.
TopMedTalk.
TopMedTalk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org, that's ebpom.org, topmedtalk.org.